Good evening, everyone. Good evening, and welcome to tonight's Your Health Lecture Series event. We're really glad that you came. My name is Bob Link. I teach microbiology here at GRCC, and I'm really pleased with the topic for tonight's lecture. A special thank you to our sponsoring organizations that are responsible for bringing us this lecture this evening. Michigan State University College of Human Medicine, Spectrum Health, and GRCC have teamed up to co-sponsor tonight's lecture. Please join me with a round of applause to thank our sponsors. And I'd also like to thank you all for coming. For GRCC biology, physical science, nursing students, I hope that you pick something up tonight that might carry with you as you go forward to your career and have to speak with your clients and patients about vaccines and immunizations. To GRCC preschool and child development students, if you're here this evening, I hope that you take something home with you that enables you to have good conversations with parents who are concerned about the health of their children and their families. And to all of you from the broader Grand Rapids community, a sincere welcome to GRCC. And I hope you also take something home with you from tonight's lecture that helps you make good, solid, informed choices about your health, your family's health, and your children's health. So Dr. English will speak tonight, and he'll speak for some time, and then we'll open the discussion up for questions and answers. We'll have a couple microphones circulating. We do ask that you ask your questions into a microphone so that those are recorded on the tape. And I know that some of you have 8 o'clock and 8:15 classes. So as we approach that Q&A time, that might be a nice time to be able to sneak out and get to your class. Or if the discussion is good, you're welcome to stay right up to 8 o'clock as well, okay? So thank you for coming tonight. I would now like to introduce Dr. Dan Magee, a pediatric specialist from Spectrum Health, Helen DeVos Children's Hospital, who will introduce our speaker for the evening. Dr. Magee.
I'm Dan Magee, and I'm a pediatric hospitalist at that big blue building across the street. I'm also an immunization advocate, and that's why I think Keith asked me to introduce him tonight, because he is also an immunization advocate, but more importantly, he's probably smarter than me. He is the professor and the chair of the Department of Pediatrics and Human Development at MSU's College of Human Medicine. As you'll be able to tell by his accent tonight, he is a native of Texas and earned his MD at Baylor in Houston. He earned his pediatric residency and fellowship at Baylor College, where he was the chief resident, and then he went on to do his pediatric infectious disease fellowship at the University of Washington Seattle Children's Hospital. He joined the faculty in the Department of Pediatrics at the University of Tennessee Health Science Center in 1990. In 1996, he was appointed the chief of the Division of Pediatric Infectious Disease at Le Bonheur and was promoted to a professor of pediatrics there in 2000. He played a leading role in the Memphis community responding to the 2009 H1N1 influenza epidemic, which earned him the honor in the Tennessee chapter of the American Pediatrics as Pediatrician of the Year in 2010. He's a member of the American Pediatric Society, the Society for Pediatric Research, the Infectious Diseases Society of America, the Pediatric Infectious Diseases Society, and the Southern Society for Pediatric Research. I'm not sure when he has time to go to work. But in 2008, he won the highest honor bestowed by the Society for Pediatric Research, and that's their Founders Award. He has been a member of the Pediatric Infectious Disease Subboard of the American Pediatrics since 2008, and he is now he has served as the medical editor of the Pediatric Infectious Disease Subboard. That means that not only is he board certified, but he wrote the questions for the test, which I'm not sure is fair, Keith. In 2013, he was recruited to come to MSU's College of Human Medicine to chair the Department of Pediatrics and Human Development. In that role, he works closely with the leaders of Helen DeVos Children's Hospital in building pediatric programs in Grand Rapids in clinical sciences, education, and research, as well as doing that for other campuses of MSU around the state. And now here's Keith English.
Thank you, Dan. Thank you. Thanks very much. Thank you for those kind words. It's a pleasure to have Dan here to introduce me because I greatly admire the immunization advocacy that he has been doing throughout his career. And in fact, I learned about that when I first visited here before I met you, Dan. So I am a relatively new chair of the Department of Pediatrics, but I've been here for 3 years now. I'm the first chair to live in Grand Rapids, and while I have responsibilities for multiple campuses, Grand Rapids is my home, so it's particularly nice to be here tonight. I'm also always been very interested in talking to young people who want to plan careers in health-related areas, whether it's medicine, nursing, and allied professional areas, because I think there's no better time to go into business of healthcare than today. It's the greatest opportunity we've ever had to improve the lives of our patients. So don't believe what you hear from people about, well, there's too much paperwork and it's too much of a hassle. Yes, there are obstacles that you have to put up with in order to practice medicine or be in healthcare related fields, but they're worth it because the opportunities today are tremendous. So I'll come back some other time maybe and talk to you about the future of medicine, this idea of precision medicine, something that we're trying to develop in pediatrics at MSU across the state. But today, I want to talk to you about something that I've always been very interested in since I was a student and a resident and then a fellow and young faculty member, and that's immunizations. Next to providing clean food and water, pure water is probably the single most important factor that's prevented human infectious diseases over the years. Second in the list is immunizations. Antibiotics are about 38th on the list. So for all the good that antibiotics do, they're a drop in the bucket compared to strategies that actually prevent infectious diseases in the first place, like immunizations. So today, I'm going to talk to you about immunizations and tell you that millions of lives have been saved by immunization. So here's a brief outline of what I'm going to talk about. It's really a brief history of immunizations, just a slide or two, a little bit about how immunizations work. Many of you know that already. A few slides about this incredible global impact of immunizations, literally hundreds of millions of lives saved. And then finally, a bit more of a personal story about a vaccine that virtually eliminated disease caused by one bacterium called Haemophilus influenza type B, or HIB. The development of this vaccine and its introduction into clinical medicine has really affected the greatest positive change of any one thing in my career in pediatrics and pediatric infectious diseases. So I'll share that story with you. So anybody know who this is? You may have seen this painting before. It's not a very good, I'm sorry, the resolution is pretty poor on the image. That's Edward Jenner. So Jenner gets the credit for, quote, inventing smallpox vaccine using cowpox to prevent smallpox. He really didn't invent the vaccine, and he wasn't the first person to make the observation, but he does get credit for bringing it to the attention of the medical community and recommending it at a time where there was great skepticism that it could possibly work. The people who actually made the observation were farmers. Farmers in Germany and Holland and many other parts of the world noticed that when smallpox swept through a community, sickening and killing many people, amongst the people that usually did not get infected were milkmaids. And milkmaids often had lesions on their hands that were pox-like lesions that looked somewhat like smallpox lesions. It was a different virus, and frankly, it's a miracle that that strategy actually worked. Had, for example, Jenner or somebody else thought that by immunizing you with lesions from the chickenpox vesicle that would prevent smallpox, that, of course, would not have worked. But this did work. So it turns out that Jenner took this observation made by farmers about milkmaids not getting smallpox, actually then did develop and test a vaccine. I won't go into the ways of how he did it because none of them would have passed the IRB today. I don't think I would approve a study where you said, I'm going to give your child this immunization and then I'm going to challenge him with live smallpox virus. That's okay with you. Of course, nobody knew what a virus was, but they knew if they challenged you with a lesion from somebody who actually had smallpox, you might get sick and die. and that the vaccine might prevent that. But nonetheless, turned out he was right. Not only did it work, but 200 years later, smallpox was eradicated from the globe. Really the only infectious disease where we can say that today. We're close with polio, but we're not quite there yet. So then in the late 18th century, Jenner developed the smallpox vaccine. 100 years later, Pasteur, probably the greatest genius in the history of microbiology, developed a rabies vaccine that did work. The year before I was born, in 1956, the first polio vaccines were developed. There's a long story about that, worth a separate lecture sometime. But something that a lot of people don't know is the people that won the Nobel Prize for the polio vaccine were not the feuding scientists who developed the vaccines, Jonas Salk and Alfred Sabin, but rather the basic scientists who figured out how to grow polio how to grow polio virus in cell culture. Enders, Weller and Robbins won the Nobel Prize for developing that polio vaccine. They won it a few years later, but 1955 it was introduced. If you go to Boston Children's Hospital, you'll see the research building there today is called the Enders Research Building to honor Dr. Enders. So the polio vaccine came out in 1955. Endemic polio has been eradicated from this hemisphere. We haven't quite eradicated it from the globe. And then 1979, smallpox was eradicated. So those are a few highlights, but I want to tell you a story. I'll come back to this story in a minute about this bacteria called Haemophilus influenza type B, or HIB. So I was a pediatric resident in Houston, Texas in 1985 when the first HIB polysaccharide vaccine came out. That vaccine was only effective in older children, and unfortunately this was a disease of infants. 3 years later, the first, quote, conjugate vaccine was licensed. I'll show you a picture or a cartoon of what that's like in a minute. And once that vaccine was introduced, this invasive disease was almost wiped out in the United States. And I'll show you some of that data. 4 years later, the people that figured out how to make a conjugate vaccine, Anderson, Smith, Robbins, and Schneerson, won the Lasker Award for developing the first conjugate vaccine. We have other vaccines today, and it's widely been assumed that one day they might win the Nobel Prize for this, but they haven't won it yet. Many Lasker Award winners do eventually win the Nobel Prize. So we'll come back to HIB in a minute. So how do vaccines work? It's not really rocket science. There is a form of immunization that's passive administration of antibody or serum. In fact, this was in common use long before any of our modern vaccines were around. And that works for a short period of time, but not for a long period of time. So for example, if you're a patient with cancer with a weakened immune system and you're exposed to somebody with chickenpox, we can give you a form of immune globulin taken from human serum donors that's enriched for activity against the chickenpox virus, also known as varicella, and that can provide protection to you after an exposure. But we'd have to do it every time you got exposed, so it's not nearly as good as an active immunization. So for the rest of the day, we'll just talk about active immunization. Active immunization basically tries to mimic natural infection without the risk of the natural infection, so to fool the immune system into mounting the sort of response that would lead to protection. That's a problem for something like HIV, where we don't know what those correlates of protection are. That's one reason we don't have an HIV vaccine yet. But for things where we know what protects you, if we know it's antibody against tetanus toxin that protects you from tetanus, we can make a toxoid that fools the immune system into mounting the same sort of response that won't protect you then when you're exposed to tetanus. So that might be actually a whole organism that's been inactivated or weakened. It might be part of an organism, like the hepatitis B vaccine just uses the surface antigen from hepatitis B. And in all these cases, the idea is to get an immune response that will protect you from later challenge. That immune response, like I say, might be directed against a toxin. It might be against some virulence factor that's invasive. It might neutralize the pathogen, and that immunity might last for a long time, or even in some cases for a lifetime. So the way that they work is pretty straightforward. The way that they're developed has actually changed dramatically in the past few years. There's something called reverse vaccinology I won't have time to talk about today, but it fits with the whole genetic revolution, figuring out smart ways to predict what will protect us against a pathogen instead of measuring the serum of people who've survived the infection, sort of the traditional way that it was done. So let's talk about the global impact of vaccines, and then I'll tell you the story of HIB. So the impact of vaccines in the United States is really quite phenomenal. This is a chart from the CDC. It's been updated many times. I think this is one that was published in 2008 and used 2006 data. Basically, you can see that if you look at the baseline number of cases reported in the United States early in the 20th century, and you compare it to how many cases there were in 2006, you can calculate a % decrease. So measles went from 500,000 reported cases, and by the way, that's not all the cases. There would have been many more, but 500,000 reported cases to 55, 99.9% decrease. 175,000 cases of diphtheria to 0 cases in 2006. And even a vaccine that doesn't work as well as some of the other vaccines, the one for pertussis or whooping cough, from about 150,000 to 15,000, so almost a 90% reduction. Obviously, smallpox completely eliminated, 100%. Rubella, virtually 100%. There's really no endemic rubella or measles in the United States now. It's got to be brought in from another country. You can still have an outbreak if we have people here who are not immunized. Polio, 16,000 to 0 cases. Tetanus, 1,300 to 40 cases. And then Haemophilus influenza type B, I'll come back to in a minute. 20,000 cases around that in the early part of the 20th century, for that matter in the late part of the 20th century when I was in residency training in the 80s, 20,000 cases a year, 29 cases in 2006. We'll come back to that. And as dramatic as those numbers are, if you crunch the numbers, that's something like 732,000 deaths prevented in the 20 years from 1994 to 2014. It's around 332 million illnesses prevented. And during that time, and even slightly before that, polio, measles, rubella, HIB, all virtually eliminated in the United States, except for this potential for the imported cases that I mentioned. So as dramatic as that is, though, that's a drop in the bucket to the worldwide impact of vaccines, where it's really estimated that over time, hundreds of millions of lives have been saved. Now, how can I say that? Well, I can tell you that we think 300 to 400 million people died from smallpox in the 20th century alone. Nobody's died from smallpox since 1979. The last native case was 1978. There was a case in 1979 from a tragic laboratory accident in England. And there have been no cases since that time. So if you just took a conservative estimate and said, well, if it had half that many cases, we probably prevented 150 or 200 million. It's estimated by the WHO today that about 2.5 million deaths are prevented worldwide each year by existing vaccines, and there's potential to prevent more. The WHO, for example, estimates that since 2000, about 17 million deaths from measles have been prevented. People that have never seen measles think, well, what's the big deal about measles? You just get a rash and your eyes are watery. What's the big deal? Well, measles kills people. It particularly kills children, and it kills young children, particularly when they're not very healthy, they don't have good nutrition, etc. So measles is a devastating disease worldwide. 17 million deaths prevented in the last 16 years. And even though we're doing pretty well, thanks to groups like Gavi and the Gates Foundation, which are providing money to roll out vaccines now in resource-poor areas all around the world, we still got work to do. So about 17% of deaths in children today around the world are vaccine preventable. That's somewhere around 1.4 to 1.5 million children who are dying now from diseases that we could prevent with immunization. So we're working on this. Here's that WHO estimate of the 1.4 million deaths. They just break it down here. You'll see that measles is the big winner. Even though we're preventing a lot of cases of measles, they're still causing 33% of all these deaths. HIB, we have an opportunity to prevent HIB elsewhere in the world the way that we do in the United States. Pertussis, and you see tetanus up there, including neonatal tetanus. Worldwide, tetanus is a big cause of death in newborns when a baby is delivered in an unsanitary circumstance where the umbilical cord is contaminated with soil or other materials that contain tetanus and the mom's not immunized. That baby can get neonatal tetanus, which is often fatal. So that's not something we have seen for many years in the United States. All right, so that's a little bit about the overall impact of vaccines. So let me tell you a more personal story about Haemophilus influenza type B, a scourge of our patients when both Dr. Magee and I were in medical training. So the story of Haemophilus influenza type B goes back a few years before Dr. Magee and I were born. It goes back to the late 1800s, when a German physician and bacteriologist named Pfeiffer, Richard Friedrich Johannes Pfeiffer, described this bacteria under the microscope, which was a small, now gram-negative pleomorphic rod, which he called Bacillus influenzae. He made an important discovery, and he gave it a bad name. He found this bug in the sputum of people dying of influenza and falsely thought that maybe it was the cause of influenza. We didn't know anything about viruses at the time. It was years before the influenza virus was discovered. So Bacillus influenzae doesn't cause the flu. It was present in the sputum of some patients with influenza, but nonetheless, it turned out to be an important discovery. A few years later, still called Bacillus influenza, then eventually called Haemophilus, blood-loving. It doesn't grow on routine media. You need enriched media where the blood has been hemolyzed, like chocolate media from the micro lab. That's how you grow Haemophilus influenzae. So the name was changed to Haemophilus, blood-loving. Haemophilus influenza, even though it didn't cause the flu, turned out to be a very important cause of bloodstream infections, meningitis, and other infections in young children. So the very first case of Haemophilus influenza meningitis was reported, 2 cases, in 1898. And then a few years later, Margaret Pittman, a giant in the history of microbiology, who also did incredibly fabulous work on our understanding of pertussis, among other things, worked on this pathogen called Haemophilus influenza at the Rockefeller Institute in New York. By the way, she later became the first woman director of an NIH lab in 1957. Her contributions to the field have been really awesome. She discovered that there were 2 types of this organism, Haemophilus influenzae. There were these transparent colonies, and she figured out that they caused respiratory infections, and she figured out later, with some assistance from others, is that they didn't have a polysaccharide capsule. They were so-called non-encapsulated, and in the literature later that became called non-typable, because the ones that did have a polysaccharide capsule that were smooth were opaque and iridescent, and they caused invasive infections like bloodstream infections, bacteremia, and sepsis, and meningitis. They had a polysaccharide capsule, and you could lump them into 6 groups, A, B, C, D, E, and F. Turns out later, almost all the invasive disease was caused by one serotype, type B, or HIB. So Dr. Pittman figured that out and published in 1931 that Haemophilus influenza could be divided into these encapsulated, serotypes A through F, and then the non-encapsulated or non-typal ones. By the way, the non-typable ones are still important human pathogens. They cause a lot of ear infections in children. They cause bronchitis in adults. They can cause pneumonia, but they almost never cause bloodstream infections or meningitis. So Dr. Pittman then figured out that some of these strains had this soluble substance. Other people later figured out that was a polysaccharide capsule. There was a difference in the pathogenicity. She figured out these serotypes. And then very importantly for the development of vaccines, she showed that if you took this capsule, even when she wasn't even sure that it was a capsule, and you took it and you immunized animals, you could get antibodies against that could protect from challenge with the pathogen. So antibodies against the capsule were protective. That was a key insight into developing a vaccine against Haemophilus influenza. So this was a big problem. So notice that in Dr. Pfeiffer's honor here in the 1930s, this report from Boston Children's Hospital still referred to the Pfeiffer bacillus meningitis, and that when they looked at cases of bacterial meningitis they had there, it was the leading cause of bacterial meningitis in children from 1933 to 1936. It was more common than pneumococcus, more common than hemolytic strep, which probably mainly group B strep, although I can't tell from this article, meningococcus, and TB. And this was a bad disease. So in the pre-antibiotic era, if you got Haemophilus type B meningitis, you died about 91% of the time. And the few survivors were usually neurologically devastated. So there were almost no normal survivors of H. flu meningitis. So in the pre-antibiotic era, it was a death sentence. By the time that the vaccine rolled around, and a little bit after that in England, the mortality had dropped to less than 10% based on antibiotics, intensive care, and other things that we could do. So the disease was not nearly as bad, but even the survivors could have serious sequelae, including paralysis, blindness, deafness, seizures, learning disorders, etc. So it was a dangerous disease that killed a lot of children and caused a lot of neurological sequelae in other children. The next observation that was made about the epidemiology of Haemophilus influenza type B, and I love this study. This was the favorite study of my mentor, Ralph Feigen, the great chair of pediatrics at Texas Children's Hospital. I heard this story from him many times as a medical student. Dr. Fothergill and Dr. Wright had noted, among other people, that there was this interesting relationship of H. flu type B or Hib meningitis to age, and you can see it over here. You can't read this down here, but this is the first year of life. Here's the second, third, and fourth year, and you can see that almost all of the children who were getting H. flu type B meningitis were infants or toddlers. It was very rare after 5 years of age, and this was known for quite a while, but nobody knew why. Well, what Dr. Fothergill and Dr. Wright discovered when they started looking at the serum of children aged less than 1 to 2, 3 to 5, not including some of the children who had known to have meningitis, but if you just looked at children in general, what you discovered was that there was something in the bloodstream of older children that would kill H. flu type B that wasn't present in the infants. And you can put these two curves together and show how, the slopes are pretty similar. Here's the disease going away, and here's the substance going up. And that substance is neutralizing antibody against the capsule that Dr. Pittman had discovered. So it turns out that by the time you're 5 or 6 years of age, even though you've never been sick from it, or maybe you have, maybe you haven't, you've been exposed to Haemophilus influenza type B and you've created an antibody to it, and you're not going to develop meningitis caused by Hib anymore. And so this discovery, that and Dr. Pittman's previous discoveries obviously suggested that if you had a vaccine that could generate antibodies against that capsule in these young infants, so you could have this neutralizing power back here, that should prevent the disease. And guess what? It did. So Fothergill and Wright, they reported that the disease disappeared after the first few years of life at a time this natural immunity came along. And then they helped, and others helped understand that it was antibody in the blood that was bactericidal that killed these bacteria that protected against the disease. So all this happened before I came along to train in pediatrics in the 1980s at Baylor College of Medicine and Texas Children's Hospital. So when I was a medical student and a resident, Haemophilus influenza type B was still the leading cause of bacterial meningitis in children in the United States. As a matter of fact, it was more common than all the other causes put together. It caused something like 55 to 60% of all pediatric meningitis. And it was so common that at a busy children's hospital like Texas Children's, we had more than 100 children a year admitted to the hospital with invasive H. flu disease, either meningitis, sepsis, or both. 100 a year. So what that meant was that I was never ever once on the wards at Texas Children's Hospital without at least one patient on our medical team who was being treated for Haemophilus influenza type B disease of some sort. Never happened. Because remember, that was an average of 8 or 9 kids a month that were being admitted, and they were being treated 10 to 14 days. They were always in the hospital. It was one of the most common things that we dealt with. Now this disease has been virtually eliminated by the vaccine, as I'll show you. Here's the overall disease burden. This is just showing what I mentioned before, much more common. This is looking at the way an epidemiologist would, how many cases per 100,000 at-risk kids. And the incidence is highest there between 6 and 12 months of life. It's actually lower in the first few months of life because you may get protective antibody from your mom during pregnancy. But once that goes away, you're very susceptible, 6 to 11 months. So this was a bad disease. Here's a little baby with H. flu meningitis. you can't tell this, but the soft spot, the anterior fontanelle, is swollen from all the increased pressure in the brain. Here's the germ itself on a gram stain of the spinal fluid. Here's what a CT scan looked like on a patient that had all this brain swelling and now accumulation of fluid outside the brain. A terrible disease. It caused really bad infections of the soft tissues like this periorbital cellulitis in an infant. It commonly caused this facial or buccal cellulitis, and many of these kids had the bacteria in their bloodstream, and so they were at risk of developing meningitis also, even if they didn't have it when you first saw them. And while you can't see this, I don't think, I know that Dr. Magee knows what this is showing, which is, this is a swollen epiglottis. The epiglottis is a piece of tissue that usually doesn't do much in your body, but it sits at a really bad place. So if you get an infection there and it's swollen, it can block off the glottis and all of a sudden you can't breathe. So kids could die from epiglottitis, from H. flu, because they would really die from respiratory failure because they couldn't breathe. Could cause pneumonia, and it could cause this kind of awful bloodstream infection that led to necrosis of the digits, something we still see more in Meningococcemia today. So this was a very bad disease, and thank God this vaccine came along to change that. The first thing that happened was somebody purified that polysaccharide from Haemophilus influenza type B, and they made that into a vaccine. You may remember my first slide. That vaccine was licensed in 1985. That's the top panel. The problem was that in a young infant, a polysaccharide only triggers a minimal immune response. You make some IgM antibody, you don't really have a memory response, and the next time you're exposed to the germ, you don't have much immunity. So this vaccine, good idea, didn't work under the age of 2. And remember my slide about where most of the meningitis was between 6 and 12 months of age, and 85 or 90% of it was by age 2. So it was terrible. We had a vaccine that only worked in older kids that didn't work in the kids we need to protect against the disease. And that's when Dr. Anderson and Smith and colleagues, Schneerson and Robbins, went to work. They had this idea, what if we fool the immune system into thinking that the polysaccharide is actually a protein antigen? Young infants respond just fine to pertussis toxin or tetanus toxoid. We give DPT immunizations at 2 months of age. So what they did was they chemically linked the polysaccharide to a carrier protein. It doesn't matter what the carrier protein is. It was, in fact, sometimes one of these toxoids. And when they did that, lo and behold, the immune system responded to it like it did to a polysaccharide antigen. Number one, you got a much more vigorous response the first time you saw it. And then when you gave the second dose, you got this booster effect, which was really the key. The second time, you got isotype switching to IgG, and you got a boosted response. And that's where the bang for their buck was. It was the second dose of Hib vaccine all of a sudden gave you tremendous protection. And by the time you had the third dose, you had a little bit more. So all of a sudden, we had a very effective vaccine that fooled the immune system into thinking it was a protein vaccine. There, Dr. Smith and Dr. Anderson, they got this licensed. I showed you they won the Lasker Award. And here's what happened. So by 1987, we still had 11,000 cases of Haemophilus influenza disease. The vaccine was licensed for children 18 to 59 months there. In 1990, licensed for young infants, the conjugate vaccine, and you can notice that Haemophilus disease just fell off the map. It was down to 300 cases by 2000, and by 2012, there were 30 cases. And all of a sudden, places like Texas Children's that used to have 100 cases a year might see 1 case every 5 years. It hasn't been eliminated, but it's been knocked down to a very low level where many of our trainees in my field of pediatric infectious diseases have never seen a case of this disease, even though it was far and away the most common disease that we saw when I was a resident. So this has been transformational in my career. This vaccine has been incredible. It's also the basis of the newer pneumococcal vaccines and the new meningococcal conjugate vaccine using the same strategy, tying a polysaccharide to a protein carrier. So I think I'm going to stop there, and answer any questions, because I wanted to have a little time. It's only 7:35. I can talk more about the Haemophilus vaccine. Oh, by the way, I didn't do this, but I wanted to thank my friend who recently retired at the University of Michigan, Dr. Janet Gilsdorf, for sharing some of those historical slides with me. These slides were a mixture of my slides and some of the slides that she showed when she gave a talk at the Pediatric Academic Societies a couple years ago. So I'd like to thank Dr. Gilsdorf for sharing those with me. So Haemophilus vaccine had this huge impact during my career. Measles vaccine was already eliminating that disease. I saw very little measles when I was in training already in the 80s. Most of the measles I saw was when I was in South America on medical mission-related trips. I never saw much measles in the United States. Many of you know we've had some resurgence in measles in recent years in unimmunized populations. So what questions do people have for me about vaccines in general, about what I had to say, or any other aspects as well?
We do ask that you have a microphone for your question so that your question can be recorded on the videotape.
And I may call on Dr. Magee to help me answer some of these questions. His experience is similar to mine.
What do you say to parents who are concerned either because they have a history of autoimmune disease in their family, or they're afraid they might belong to a small subgroup of people genetically or whatever that may have a unique adverse reaction to a newer vaccine, such as like H1N1 in Northern Europe, where there was the weird narcolepsy correlation?
Yeah.
What do you say to parents who are concerned about newer vaccines on the market, like Gardasil or something like that?
So it's a good question, a couple of good questions. I'll tackle Gardasil in specific in a minute. But so what you start off with is, first of all, we should always take any concerns that parents express about their kids' health seriously. And we should always say, we know you're worried about your child and you want to do the right thing for your child. So that's where it should start. It should never start by being dismissive or by saying, well, we know that vaccines don't cause autism. We do know that. But dismissing it and not dealing with it as a serious concern is not going to be effective. By the way, there are studies that show that if you look at parents who are vaccine hesitant, they either don't want to immunize their kids, or in some cases decide they're not going to immunize their kids, or they're not going to give them a specific vaccine. The evidence is about half the time they can be persuaded to immunize their kids, and about half the time they cannot. And so it's worth trying to talk about the concerns and address them seriously with the opportunity to change their mind in some cases. The specific thing about a new vaccine is interesting, because of course it's true that any new vaccine cannot have been used as widely as a vaccine we've been using for 20 years. And vaccines do have side effects, don't get me wrong. Every vaccine has potential side effects. But overall, they're some of the safest medical interventions we've ever had in our lives. I mean, Tylenol can cause liver failure if you take too much of it. It's one of the safest drugs known to man. Vaccine side effects are rare. We should say they do occur. They're not common. And when there are specific concerns about a vaccine, about does the human papilloma, should I give the HPV vaccine, vaccines, there are multiple ones now, to my children, to address a concern about a side effect, we can say that hasn't borne out. We've been looking at that very carefully. It's not a problem. You shouldn't worry about that. So we can say that in terms of specific concerns. I'd never tell a parent, well, it's a new vaccine. There's no way there could ever be any rare side effect that might affect your child, because I don't know that. But I can say that vaccines are never on the market, never, without a lot of testing, first, preclinical testing and then testing in people to show that they're safe and effective. That's not true for most of the things that you can get at your local health food store, right? Most of which have not been required to be shown to be effective at all, and in many cases haven't really even been adequately tested to be safe. So I think we can say they're tested carefully. Here's why I would give this vaccine to your child. I understand your concern, but you start by taking the concern seriously. You don't dismiss it.
Next question. Yes, can you speak to the increase in incidence of different types of illnesses because parents are not immunizing, and the trend that's been ongoing for several years?
Sure. This is one of my favorite topics, so I need a soapbox I can stand up on here. This is my favorite, so I didn't plant that question, I swear. Yeah, so that's the problem, right? Is we're not, in human beings, by the way, don't expect the parent who's worried about their child to be somebody who's got a calculator who's going to calculate the relative risk of doing X, Y, or Z. That strategy does not work. As human beings, we tend, we know this, for example, when we talk to parents about prognosis for an illness. The way that we describe it makes a big difference in the way that parents look at it. If you lead off with the rarest of the side effects and you say, don't worry about it, it's only 1 in a million chance that it could be that, parents wind up worrying about that more than about all the other information that you give them. So you start off by laying out the facts and you say, but there are some rare side effects, and then that's usually accepted better. Well, there's no question that in my lifetime, I've unfortunately cared for children who've been sickened and died by vaccine-preventable diseases in the United States that they were not given because a well-meaning parent or someone else decided not to give it to them. One of the most heartbreaking cases I was ever involved in, I was actually called to review a lawsuit once against a homeopathic physician who did not recommend immunizing children. The parents sought him out because they didn't want to immunize their children. And then when their child got a vaccine-preventable disease and died, they sued him for not immunizing them. And I said, gosh, that doesn't seem fair, I mean, I don't agree with this guy's recommendation. He had, in fact, told the parents when the child was sick, go to the emergency room. This is above what I know how to do. You should go be seen. They didn't do it. And I don't want to blame the parents in this case. It was a tragedy, but certainly it wasn't his fault if they sought him out. I think most of you know of recent outbreaks of measles at Disneyland, of pertussis in Traverse City. There have been outbreaks in unimmunized populations of dangerous diseases that have sickened and in some cases killed children in this country. Polio would have been eradicated worldwide already, almost certainly, had it not been for a very complicated political dynamic where folks in particular countries, particularly Nigeria, were suspicious of the United States and its intentions in immunizing children in that country that led to reluctance to get children vaccinated there. So this is a complicated equation. It's not easy. The thing that personally angers me the most in my career, and I'll show you this slide. I usually bring this slide along in case I'm asked about it, is the story of Andrew Wakefield. So for the students, I want to tell you the story of Dr. Wakefield. This is a quote from Lawrence Altman, who was an EIS officer. By the way, that's the Epidemic Intelligence Service. That's the people the CDC sends somewhere to investigate an outbreak and figure out what the heck's going on. He took a cushier job later in life as the medical consultant for the New York Times. But he said, for the general public, the media are the major form of continuing education after formal schooling is complete. The greatest physician probably of all time, Sir William Osler, said, don't believe anything you read in the newspapers. If you see it in there and you know it's true, you should start doubting what you thought. I'm not that skeptical, by the way. I think Dr. Osler is having a bad day when he said that. But my favorite writer, Jonathan Swift, got it right. He said, falsehood flies and the truth comes limping after, so that when men come to be undeceived, it's too late. The jest is over and the tale has had its effect. And that's what happened with this guy, Andrew Wakefield. Andrew Wakefield is a physician, now disbarred, in England, who had an idea that maybe MMR vaccine caused autism. Now, Dr. Wakefield didn't have any data to support this idea. Dr. Wakefield had an arrangement with a lawyer who wanted to sue companies that made the vaccine. Dr. Wakefield put out ads in the newspaper to get parents to come to see him if they thought their kids had developed problems because of MMR. Dr. Wakefield published a really bad study in The Lancet that was later retracted, claiming that he had found measles virus in the intestine of kids with autism and that it appeared to be the cause of autism. We found out years later that Dr. Wakefield made up some of the data. He wasn't just a bad scientist, he was a fraudulent scientist. He made up data. An investigation from the British Medical Journal led to this, an elaborate fraud article about Dr. Wakefield about 5 years ago. He had his medical license taken away. So here's the guy that his work, without question, convinced some people not to immunize their children with a vaccine that put them at risk of being sickened and dying from a dangerous infection. So this is about as bad as it gets in my career. This is the opposite of the Haemophilus influenza type B study. By the way, when the Haemophilus influenza type B vaccine was first licensed and all these kids' lives were being saved by it, there were some anti-vaccination folks that said, you know, it seems like a good vaccine, but actually we think it's causing diabetes and some other human conditions. And what they showed, and I'll go back to one of my graphs, they showed a slide that showed the opposite of this. It showed the vaccine uptake going up, and they showed another slide that showed diabetes incidence going up, and they said, see, the two slopes look similar. Those of you who've had a scientific background realize that's not a very good argument. So I went to a meeting that year when one of the world's vaccine experts talked about that argument, and he showed a slide of CD sales increasing. Those of you in the audience don't know what a CD was, but it was way back before DVDs. A CD sales go up in the United States had the same slope. He said, by this argument, I can't tell whether vaccines cause CD sales or CD sales cause vaccines or both of them cause diabetes. There was never any biological plausibility to that argument. It was a terrible argument. And there was never biological plausibility for MMR causing autism. As a matter of fact, one of the components in MMR, the minor component really, the rubella vaccine, has without question prevented many cases of autism around the world. Not in the children who get the vaccine, but in their moms. Congenital rubella syndrome in the United States was a terrible problem. It used to affect about 20,000 kids a year in the 60s. And those poor children in the womb were infected with rubella. They had microcephaly, like you now see with Zika virus. They had cataracts. They were often deaf. They might have seizures and other problems. And when they grew up, they had a high rate of autism, among other neurological conditions. That disease, congenital rubella syndrome, has basically been wiped out in the United States because of the MMR vaccine. So it's ironic that not only is there no evidence that a vaccine causes autism, preventing some of the infections in the moms that the moms have while they're pregnant actually may be preventing autism. So, other questions? We need better vaccines. We shouldn't be satisfied with the vaccines we have today. What are the problems with vaccines? We have to give too many injections to kids. Nobody thinks it's a great idea that you have to go to the doctor and get several different injections. Nobody likes the fact that I got to give you a different flu shot every year because the one I gave you last year doesn't protect you this year. We need better vaccines. We need ways of giving vaccines together. And we frankly need more vaccines that don't have to be given by an injection. Wouldn't that be a nice world? We got rid of the oral polio vaccine because unfortunately, rarely, it could cause polio in immunocompromised patients, so we quit using it. But prior to that time, believe me, it was the one that children would have voted for as their most popular vaccine. I got a sugar cube versus you're going to give me a shot, I'll take the sugar cube. But we need better vaccines. We shouldn't be satisfied with what we have today, but vaccines have saved so many lives. Yes?
Thank you for taking my question.
Sure.
So my question is, about 10 years ago, I had a hepatitis B series, and I actually developed the side effect where you have, after the second and third, you have this severe joint pain. So it's kind of like gout for months and months. So I ended up going through lots of rheumatology testing, and eventually it resolved. So I have children. Is that, in that type of situation, would that be something where I would say they might have a tendency, it's not crucial for them?
You know, we don't think so, but it's a good question. And thank you for telling us your story, because nobody should ever tell anyone, oh, don't worry, there's no way you can have a side effect from a vaccine. There are side effects from vaccine. Thank goodness they're mainly mild. Children that get the DPT vaccine on their 4th and 5th dose can get a strange swelling of their leg that looks really dangerous. Turns out not to be serious, thank goodness. But that can occur. We know other things can happen. I don't think there's any evidence that that's more likely in your kids because you had it, but it's a good thing to review with your doctor. Ask them to look into that, see if there's any more information about that before you give them the vaccine. I mean, we want kids fully immunized, but there are some valid medical exceptions for certain vaccines. If you are allergic to a component in a vaccine, and that happens sometimes, it may be that you can't get that vaccine. And in the future, frankly, the current vaccine strategy would be much better if we had precision medicine down the road. It might be that we could tell in advance that we shouldn't give you the regular hepatitis B vaccine because you might have a reaction. Instead, we're going to give you a new or different version of the vaccine that would be safe. We do that a little bit for flu vaccine because we've got an inhaled form and an injectable form. We're not using the inhaled form this year because of some problems with it. But in years that we have both, there's certain people that should get one and not the other, and that's sort of a slow start toward precision medicine for vaccines. We need to understand that better. So, and we need vaccines against HIV. We need a better vaccine against tuberculosis. We need a vaccine against malaria, right? So we've failed in many cases. We need a vaccine against staph. MRSA, Staph aureus, that's the leading cause of death caused by bacteria in the United States today. We don't have a vaccine against staph. It's not because people haven't been working on one, they've just been totally unsuccessful. Any other questions? Yes.
Thanks for taking my question. I'm a student of pharmacy up at Ferris State University, graduate of GRCC. I just wanted to ask, as many of us here are future healthcare professionals, wanted to ask, what can we do now to advocate for vaccines within our communities, within like our present jobs? Some of us work already in like healthcare subfields. What is it that we can do now to advocate for that, and then maybe encourage it when we're in our
it's a good question. I think that you're making a very important point, which is this is not something that people are going to decide about if they're hesitant about vaccines during that one visit to the pediatrician's office. If there's reinforcement from their pharmacist, from the nurse, from their church, from other groups, it's more likely they'll do it. And part of that is being very honest. It's not telling people, don't worry, there's no way there could be a side effect from the vaccine. We should be honest. But we should say that on balance, vaccines are very safe and prevent a lot of disease, and here's why you should give it to your child. The HPV one is a good one. I'll come back to that. That's a tough one because vaccines that are given to children to prevent sexually transmitted diseases or diseases that have adult consequences have been more difficult to get going in pediatrics. If you look at the history, a vaccine for Haemophilus influenza type B was a no-brainer. We were seeing hundreds of these kids. Pediatricians embraced this vaccine. Hepatitis B vaccine was not really embraced by the pediatric community initially because you usually didn't get hepatitis B until you were sexually active or you had contaminated blood or a needle stick or something like this. So not many children got hepatitis B. It was mainly a disease of adults. And when you get hepatitis B, while it might make you sick, the long-term consequences are usually that 30 years from now you might get liver cancer or cirrhosis or both. So pediatricians were slower to embrace that. Well, same thing's true for the human papillomavirus vaccines. Here's a vaccine to prevent sexual transmission of a pathogen that if we prevent it, its great impact is going to be prevent mainly cervical cancer, also some other cancers, but mainly cervical cancer. And so again, the payoff's going to be 30 years from now, not next week. It's not going to be that we prevent something that impacts you right away. And there's been, and this is embroiled with all complicated sexual politics in the United States. And some people who had sincerely are worried that by giving their child the HPV vaccine, that means the child would think it's okay to go out and have sex. That to me seems like for anybody who's ever had teenagers, I don't think that's much of an argument. It baffles me that somebody could think that, but people seriously believe that. If I give them that vaccine, they think that gives them a license to have sex. Because I think a little one-on-one conversation with your child could dissuade them of that idea. So anyway, that's a tough one. That's one that has occasional side effects, but they're usually mild, and and it's well tolerated. And it's preventing cervical cancer, something that nobody wants to get, a terrible disease. So I do think community, it's sort of like the Malcolm Gladwell argument. It's the tipping point thing. When there's a tipping point that most people whether they're in the medical profession or you work with them or they're at church or at school, agree that immunizing kids is a good idea, that's the tipping point where most people choose to immunize their kids. And if you're in a situation where a lot of people, for better or for worse, think it's dangerous to immunize their kids, you know, it's going to be more likely that you're going to decide not to do that if you're hearing these multiple things. And believe me, Google has not been our friend here. If you Google immunizations, some of the top hits you're going to find are Barbara Loe Fisher's website and other anti-vaccination websites. So one of the things we should do in the medical professions, we should direct parents and patients to websites that provide reliable information. I have a whole list of those. So we should say, hey, you want to learn about immunizations? Go to the American Academy of Pediatrics website. They'll, you know, here's information about all of them. You got more questions? Come back and talk to me about it. That kind of thing I think is positive, but always take the concern seriously. The worst thing we can do is dismiss a parent's concern and say, well, that's stupid. Well, you know, it's not stupid. They're worried about their child. They may be worried based on something they overheard at the supermarket, or that somebody, you know, or that they heard on television or looked up on Google. But if they're worried because they're a sincere worry about their child, we should take that seriously to start with, I think. Got one back here. Okay.
Thank you for answering my question.
Sure.
You mentioned that Nigeria was the government didn't accept having the polio vaccine in that land. I'm personally from Nigeria.
Yeah.
I would like to know, in third world countries like Nigeria,
Yeah.
do you think that the result of the wide amount of illnesses and diseases and high amounts of HIVs and AIDS, do you think that it's a result of poorly vaccinated countries?
It's a good question, and no, I think that there are multiple reasons for why things like this happen. Part of it probably was the fault of the United States for not doing a better job of partnering early on in these efforts. Some of it had to do with skepticism. Some of it was involved with politics, you know. If you don't trust a country politically, you're worried that if they come in and immunize your children, maybe they're actually trying to harm them. That leads into the anti-vaccination groups. You know, people say, well, why are you doing this? You didn't help me before. You didn't care about me. You were helping my, you know, this other country. So I think part of it's involved with that. It is true that in countries with high rates of HIV infection, some of these immunizations may not work as well, and that can lead to problems that you can't get rid of it. For example, if you have HIV infection or other immune deficiency, we don't want to give you the oral polio vaccine usually. We want to give you the injectable form. It's more of a problem for people with other severe immune deficiencies. So I don't think there's an easy answer to this. I do think, though, that it's about public health partnerships, that we're the country with the most resources in the world, and it should be our moral responsibility to reach out and help prevent vaccine-preventable diseases everywhere, because it's the right thing to do. And thank goodness the Gates Foundation and Gavi and other philanthropic organizations have been putting their money where their mouth is. They've been doing this to provide these vaccines all around the world. Now, we're making progress. I think we'll eliminate polio. The original plan was to try to eliminate it by 2000. That obviously didn't happen. But thank goodness there's not much polio on the earth today. And there's a chance we'll eliminate it in the next 10 years. So I hope we do. Good question. Yes. Two more questions. One there and one up here.
Thank you for taking my question. I worked in the healthcare field for 10 years, and I have never seen more of a resistance to any people not wanting to take a vaccine as much as the flu vaccine. I hear all the time, I took it and I still got the flu.
Yeah.
Or I took it and it gave me the flu.
Yeah.
Even though it's not a live, as long as you're not getting the nasal, it's not a live vaccination. So what do you tell people who tell you all the time, I got it anyways, so therefore I'm never getting it again.
Yeah.
They don't know what they're doing.
Yeah.
That I hear those excuses all the time.
And some of the people that don't want the vaccine are doctors and nurses. They're not all, you know, I mean, we actually had in Memphis, we had to have a rule that if you didn't get the flu vaccine, you had to wear a mask the whole time. And it was almost, people said, well, are you going to put a scarlet letter on my forehead, you know? So, well, you can't be around children because we can't let you come to the hospital and work. What if you get the flu and give it to one of your patients in the ICU? They could die from that. So what's happened now is you're seeing many organizations requiring physicians and nurses to get the flu shot every year now, and even in some cases furloughing or firing them if they won't do it, or assigning them to non-clinical jobs where they don't have any patient contact until the flu season's over. I don't know where this came from. I will say this, the flu vaccine is not a fabulous vaccine. Some years it's good, other years it's mediocre. There are already worries that this year it may not be as good as it was last year because we're always making a guess about which flu strain is going to be circulating by the time we give the vaccine. So the flu vaccine is not perfect. I used to do lectures to all of the people at Le Bonheur, the Children's Hospital in Memphis, who didn't want the flu vaccine, about why it was a good idea for them to get it. And so I talked about these myths. I've got slides, the 5 vaccine myths. The first 2 are the ones you mentioned already. Well, it didn't work. I got the flu anyway. I showed them studies where people were tested after they got the flu vaccine. Yeah, if you get the flu vaccine today and you come down with the flu 3 days from now, that's because there wasn't enough time to mount a protective antibody response. So that is true. You need a week or 2. 2 weeks is best. So if you don't get it until December and then you get sick the next day, you got the vaccine too late. But what happens to most people that get the flu vaccine and still come back with a respiratory illness, guess what? It's not influenza. We've done studies. It's para-influenza. It's adenovirus. It's other things. And actually, most of them are not as bad as the flu. But you can still get other respiratory viral infections. So the fact that you get a flu-like illness doesn't mean it's the flu. And by the way, flu vaccine, like many other vaccines, does not prevent every case of flu. What it does, though, is it prevents many cases, and then the cases that you do get, on average, are much milder. So it's both incidence and severity of disease that's reduced. Same thing's true for pertussis vaccine, for example. Doesn't prevent all the cases. So I guess you start off by explaining that. Frankly, we wouldn't have such a big explaining problem if we had a better flu vaccine. We need a flu vaccine that's universal, that protects against all the different serotypes, and that you only get every 5 or 10 years, not every season. So part of it's our own fault. We've not really succeeded. People have been working on this my entire career. The idea is find some protective antigen that's shared by all the flu strains, immunize once every few years, and everybody will be protected. We're not there yet. Yes?
So my understanding is that the AAP has recently changed their guidelines to, at very last resort, you could dismiss a patient from your practice for not vaccinating. Last resort, and it used to be not at all. So my question is, what are your thoughts on that, or the practices that won't even accept you if you're not going to vaccinate?
Good question. I'm glad you asked this question. I actually have a copy of that document right here, if you want to read it, called Countering Vaccine Hesitancy, written by my good friend Kathy Edwards at Vanderbilt, who's the head of the AAP committee that worked on this. I think they're right, but I think it should be a last resort. I think most people who have kids in their practice that don't want to be immunized should work with the families and try to convince them to immunize their kids. And I don't like these unscientific, unproven, goofy immunization strategies where say, okay, we'll make a deal with you. We'll give these 2 but not those 2, or we'll give that one next year. The problem with those strategies is you wind up giving them after the critical time where the child was most susceptible. So I think in most cases you should still keep them in your practice and try to convince them to immunize their kids. However, the counterpoint, I'm going to see what Dr. Magee thinks about this. The counterpoint, and one reason the AAP wrote this, is that they understood that in some cases it might be dangerous for you to have kids in your waiting room who are not immunized and might have measles, for example, and then could give that to another child in your waiting room who had a liver transplant who might die because you allowed unimmunized patients. So what some practices have done is they said, okay, if you're not immunized, the only regular follow-up visits you can have are Friday afternoon. And if you're sick, we'll bring you in and quarantine you in a room, but otherwise you can't come sit in our waiting room. And others have said, I'm sorry, we just have to ask you to leave our practice. So Dan, what do you do and what do you think? What's the best answer here?
I don't think there's one good answer. You also have to throw into the equation those that have religious objections to the vaccine. And I'm talking truly religious objections, not the Church of Dan that was just made up yesterday to oppose vaccines. So I think you have to weigh that in as well, but I agree with if you're going to keep them in your practice, that you have to provide measures to protect your other patients. The other thing the AAP recommends is they have a waiver that they ask the patients to sign every time you come in saying, vaccines have been explained to me and I acknowledge that there's a risk of death in my child if he doesn't get these vaccines. And a lot of times that will convince them.
Yeah, yeah. You know, it's interesting. The politics of this are very interesting. As many of you may know, the state of California, about 2 years ago, after the measles, or a year and a half ago, after the measles outbreak at Disneyland, a pediatrician in the legislature in California introduced a bill that was passed and signed by the governor, making California the 3rd state that does not allow any non-medical exemptions for vaccines. So the only vaccine, I think it's 3 states, West Virginia, it may be Mississippi, and now California, do not allow any, quote, any religious or philosophical exemptions. The philosophical exemptions are the ones that I think you're talking about with the belief system that you came up with yesterday so that you don't have to give the vaccine. My favorite one is in Texas, where people would say, well, doctor, I just don't believe in vaccines. And I say, well, you have to believe in them. I can show them to you. I can go give one to this kid down the hall. What they mean is, I don't believe it's a good idea to give my child an immunization, of course. And you know, in many states now, that doesn't work anymore. And in Michigan, as many of you may know, a change in the state law requires parents who don't want to immunize their kids based on a philosophical objection to go to the health department, to listen to somebody lecture to them like I just lectured to you, and then sign a waiver. And guess what? A lot of parents don't want to bother with that. They say, oh, forget it, just go ahead and immunize them. Others do. They come, they listen, they sign the document, and they don't immunize their kids. So there's actually, the AAP in that same document suggests that it might be time to consider a nationwide ban on these philosophical exemptions. That's not likely to happen, I don't think, just because it's so ingrained. And, you know, I don't know what's going to happen. But there are 3 states now where there are no philosophical exemptions to vaccines. And it really is sad, but it really shouldn't be just about what's best for your child. It should be what's best for the other children that your child is around. And I understand. I mean, I had 2 daughters, and my daughters were very important to me. And so the best argument to me probably would have been said, this is going to affect your daughter. I understand why altruism doesn't usually outrank your protection of your own children. I get that, but surely altruism should be part of this. It should be part of wanting to do the right thing to prevent other people from becoming sick and dying from something that your child inadvertently gave to them. That should be part of this.
Dr. English has agreed to stick around for a few minutes after the talk.
Happy to do it.
If you have any additional questions, if you weren't comfortable asking in front of this big group. With that, I'd ask you to give Dr. English a big thank you, applause.
Thanks for having me. Thanks, Mark.